the concept of a regional medical operations center is to bring all of the stakeholders to the table well in advance of anything happening, to work together on planning for major events. And when I say bring all the stakeholders together, I mean, bringing together all of the hospitals, hospital systems, the emergency medical services, the public health organizations. And if all of those relationships exist up front and they've worked together on planning, and then they have on top of that a communications infrastructure that allows them to track what's happening in real time in the healthcare system, both from the hospital perspective and from emergency medical services perspective, then if something big happens, and most of these were designed for traumatic events, right? So, a big mass casualty event. But if something happens, they can immediately identify where the resources are in the healthcare system to best manage those patients. And they have a strategy to do that very rapidly, to distribute the patients in a way that doesn't overwhelm any particular hospital and allows the patients to get the best care. Now, a pandemic is, it's a slightly different scenario in that it's bigger, and it's longer. So it affects the entire healthcare system, and it extends over months, not just an immediate event. But what we've shown in this paper is that there's a lot of opportunity to use the same infrastructure, the same approach that you would use for a mass casualty event to stand up a longer standing resource that would respond to the pandemic. In this particular case, certainly in Washington State and in many parts of the country, our initial outbreak was in a long-term care facility. And long-term care facilities, which care for the elderly and our most vulnerable people in our communities, were very high risk for poor outcome from COVID, and it can spread very rapidly in that environment. So if you have this structure in place that can monitor what's happening with EMS, and you see that, wow, there were 15 ambulance transports from this one facility to this hospital in the last week, that should raise a flag that something's going on there, right? And help you identify the outbreak early so that you can intervene. You can go into that nursing home or skilled facility and evaluate, test all the patients, test the staff. You can develop a strategy to isolate and quarantine people who are not sick enough to go to the hospital. And for those people that need to go to the hospital, you can distribute them among all of the area hospitals so that the closest hospital to that facility does not get overrun and run out of staff and supplies and ventilators and things like that. So, this advantage of this structure really allows the healthcare system to be optimized. It could still get overwhelmed with huge numbers of patients, but at least this way you do your best to distribute them to where the resources are. Patients that are the most vulnerable, at least in this setting, seem to be people that live in crowded areas. And so that can certainly impact the long-term care facilities, but also impacts things like homeless shelters, jails, prisons, and parts of our cities where people have to live close together because of poverty and other issues. So if you have an active strategy to identify those places and monitor them for outbreaks, again, I think with an RMOC structure to do that, you can really be proactive at catching something before it becomes unmanageable. Because of a lot of work that had been done in advance through our healthcare coalition, which is the Northwest Healthcare Response Network, through our public health agencies, we already had all these pre-existing relationships. So when the outbreak occurred, it was recognized quickly, and communication among those entities happened very quickly. So I think that having those pre-existing relationships and good collaborative working relationships is really critical. In most healthcare systems in the United States, the large healthcare systems are in competition with each other. So they don't routinely share data. They don't want to let their competitors know, what's going on in their own system. But in this type of event, or in any mass casualty event, the whole healthcare system has to come together and work together to be effective. And so again, by having these pre-existing relationships, people are willing to share that data and willing to accept the understanding that they're going to receive patients and transfer when need be in order to balance the hospitals across the entire region. It's really key to have a data platform that you can monitor this data on, and that all the hospitals and EMS agencies and ideally long-term care facilities could submit data to. We worked in Seattle with Microsoft because they're our neighbor, and really they wanted to help in the response, and they developed a platform which has now been adopted statewide. So it's called WA Health, and it does roll up to the state level. You know, other states have had pre-existing software systems as well. So there are models to how to do that. And ideally, you know, if you think about the big picture, what would be the ideal scenario for us in the long run? It would be if every region had an RMOC, and then that was on the same data platform that rolled up, all those regions rolled up to a state data platform that the state could view the situation across the entire state. And then that data could roll up to a federal level. So we would really understand what's happening in real time across the entire country in a major response like this. That could allow us to even distribute patients across state lines, right? So you know, if one state is hit particularly hard and the hospitals there are overwhelmed, you know, perhaps there's a neighboring state that has capacity that could help in that process. So, you know, it's a vision of how we could be prepared for, you know, all major disaster events that could happen. It could be a large earthquake on the West Coast, for example, that requires a multi-state response. It could be a major hurricane, you know, so we should anticipate that these things can happen and think in advance about how we can build the best infrastructure to support that.
For a while, we were calling the fact that we were the first epicenter in North America for with an outbreak is sort of a tragic gift, if you will, because it significantly impacted everybody, even though it was relatively small, and it brought everybody to the table in a meaningful way to where we knew that it was going to take every representative from all facets of the health system to be able to stand up, work collaboratively, and in order to overcome this. One entity or one government agency or one hospital or even hospital system could not deal with this effectively. And so that warning was an effective tool to really bring people together to have meaningful conversations and to figure out what we could collectively do to meet our community's needs. And it was quite encouraging. So we had to learn a great deal in the beginning, but we realized right away that our processes and infrastructure could be extended and to deal with an infectious disease scenario, which is really when you're talking about our disaster responses. Typically, we are all trying to get provide the greatest good for the greatest number of patients, and to get patients to the right facility with what's in lieu of what's happening with their injuries or with their illness. And so we just extended that model to the entire region, to where we set up the structures to where we could work collaboratively to distribute patients throughout the entire health system and to meet different hotspots that come up, rather than having any one health system be overwhelmed, which is classically happens in a disaster scenario. And our disaster planning helps to eliminate that from happening, to where we coordinate patient distribution and patient flow so that one facility is hopefully not overwhelmed. In the early days, we realized that we did not have an effective way to really understand what was going on in area hospitals, area health systems, and area hospitals in terms of what the COVID burden was. And for us to effectively level load the entire region, we knew that we would have to share data. And we also knew from conversations that were happening that were advanced by our healthcare coalition, the Northwest Healthcare Response Network, that people were willing to do this really for, in our region, really for the first time effectively. And so we worked with Microsoft to build a data platform, which has then now been extended to the entire state. And our Washington State Department of Health now asks, or it's actually required that they submit data into this healthcare platform. So we have a window into every hospital in the state as to what their COVID burden is, what their bed availability is, what their equipment needs are, staffing needs, everything that we could want to know in regards to COVID, we now have access to on this data platform that Microsoft helped us build, free of charge, by the way. And in a funny story, on 2 successive days, we actually had Google and Microsoft both competing with each other to give us a free product that they would commit enormous resources to build purely out of public service. And that was, to me, another proud moment for our community and for our region and for the country too. I think our region and hopefully other regions across the country and across the world are now learning and growing and so for us, our data platform, our existing relationships that we worked hard to develop with operating agreements and data sharing and MOUs between health systems, we really think will allow us to proactively now, we have been proactively planning for the next surge and when it happens again. And really, as we talked about before, we could extend this to trauma or to infectious disease or to any other that we would have to deal with. And so we are absolutely confident that we need to keep those structures in place, and we're actually working towards maturing those in a way that they will be stood up on a routine daily basis to meet the needs in the community, but then also be able to expand when crises happen, such as the pandemic. Lessons learned are, one, you really have to have all of the, everybody needs to be at the table, and that's easier said than done, but we were very fortunate in that we had a proactive healthcare coalition that was able to organize a region, get senior leadership from every health system and organization, whether it be EMS, long-term care associations, which have absolutely been impacted significantly, all the health systems in our region, and as well as the local health jurisdictions or public health representation is also very key. And so we were fortunate that we had a mechanism to regularly meet, to organize ourselves, and great leadership to be able to move things forward. So that's one big early lesson. And then you have to have data sharing. There has to be a coordination center, a regional coordination center that has eyes into what is happening in every facility, because in this pandemic, we all know that when transmission happens, it typically occurs in clusters, and then those clusters will spread. But if you can have early identification of those clusters and deal with those effectively, then you can prevent spread and also, as importantly, provide great care for those people who are impacted by that. And then, of course, access to viral testing is a very significant issue. Our virology lab at the University of Washington was truly unbelievable, and I would even say heroic in turning over every single leaf possible in order to increase our testing as rapidly as they could. And they, I think, have been a model for others to learn from. We went to 7,500 tests per day for our region very, very quickly, and it was an amazing story how that happened. And I think proactive management of really having an emphasis on what is happening in long-term care, having that visibility into what's happening in long-term care facilities, having the relationships, importantly, into long-term care is vitally important in being able to organize that, and other vulnerable population groups, congregate settings like prisons, like homeless shelters. Unfortunately, our region has a significant homeless population, and so a significant effort has been made around testing and how to manage patients who are impacted by COVID, who are living on the margins or who are homeless. And then all this has to happen in the context, obviously, of governmental decisions around physical distancing and staying at home and those sorts of things. So those are the lessons we've learned, and we of course continue to learn every day.